Hi, this is Introduction to Counseling, and I want to talk to you about what treatments work best for what problems, what style of counseling for what issues, and so on. What techniques are used for what things. We have a better idea about this, and I'm going to be speaking in generalities. So, let's talk first about techniques. There are a series of techniques, a group of techniques, that we collectively call bibliotherapy, or maybe even cinema therapy as part of that. But these are for academically oriented clients. And so these are people who like to read, they like to learn, they like to study. And so you might have them read certain kinds of literature to help them understand something. They might write in a journal to process emotions or thoughts. Now, the thing that you want to do with this is you want to know what the literature is before you suggest it. You want to know, have read that or whatever. Then you want to provide discussion time because you don't want to have them do something and then not refer to it. You want to read it and then discuss it. Okay, or have them read what they want you to hear. In cinema therapy, there is a wide variety of films, and each of these can give us a different set of learnings for the client. And so the client can learn a great deal about how other people deal with things and what possible outcomes might be, what possible problems there might be. There are websites for this, several. The one I like most is cinematherapy.com. Give it a try. You can find exactly what you want by looking at general issues and then go into the general issue by clicking and then going down a list of sub-issues related to that major issue, and then click that, you'll see a whole bunch of films. Again, you want to have watched the film that you might suggest to them because you want to know if it's appropriate for them. Another technique is therapeutic confrontation. This is not yelling at people or hammering something at them. No. This is when symptoms are denied or minimized. It's an art form. It's a very gentle kind of approach to helping people break through a denial. Okay, so if somebody's using substances, let's say, and they're beginning to lose things in their life, partner leaves them, they lose a job, lose a car, whatever, they start really going down. Okay, and they don't think it's connected to the substance abuse at all. Classic substance abuse related denial. It's not actually Freudian denial, but it's not far off, and they don't see that. The wife, oh, the job sucked and I did everything. No, they don't see the connections. You might say, it sounds like that during the time when you were having these problems with your wife and the job and being able to pay for the car, that was a time when you were using a lot. And I wonder if those two things are connected. That's a confrontation. It's a mild one, but that's the kind of thing I'm talking about. That's an art form. Systematic desensitization. You have someone who has a fear, maybe a phobia, and you construct a hierarchy from lowest threatening to highest threatening, maybe 10 or 15 items at the most. And then you teach them how to relax very well, so several sessions of just relaxation exercise. They know how to do that. And then you expose them either by thinking about it in the session, okay, or in real life, probably just in your the first ones will be in your office. And when they think about that thing, they'll get anxious. They'll indicate that maybe by raising a finger or something, and then you'll go through the exercises for relaxation, and then they'll revisit that one again. If they get anxious, more so over and over and over and over. So until that number one is no longer something that creates anxiety. Works very well. Then you go up to number two, and then number three, and number four, and so forth. Right? Okay. So you start out with likely imaginal exposure, and then maybe later, with the help of an assistant, a friend of theirs, or someone from the family, they go in the real world and approach the things that are higher up on the list. Because some of those will require them to do it in situ, outdoors, live. In other words, in vivo. There's a dog back here that's breathing heavy. And then another technique is assertiveness training. And assertiveness training is for people who tend to be passive or submissive. You generally don't have aggressive people taking assertiveness training. They don't think they have a problem. But this encourages clients to stand up for their rights without being abusive, to have good boundaries, to say what they want, to say what they don't want. And there's a whole bunch of things. There's nonverbal as well as verbal approaches to this, and it works very well. It's not often done much anymore, but in the 80s and 90s, it's very common. Group work, all kinds of groups. We want to have about 10 members of the group. That's an ideal number. We want to have a group where everybody is kind of the same issues, if not the same issue. Everybody with a phobia, everybody with at least with anxiety. So they kind of get that way. There's instant empathy, instant understanding, and mutual support. I am not alone in a group like that, right? Okay. We want to teach relaxation exercises for people who are anxious. You will be teaching people, if you're a counselor, how to relax. Progressive muscle relaxation. Diaphragmatic breathing, sometimes just called deep breathing. Visualization, thought stopping, things like this. Mindfulness exercises like these are very effective. I've used them a bunch. I'm using them now with some clients, and they are responding very well to these. These are techniques and tools. They are not the be-all, end-all necessarily, depending on the issues. Role playing, better in a group, but they could do that in a one-on-one session, right? For withdrawn clients, but strangely enough, also for histrionic clients. But probably better in a group. And you get people to play different roles within their family or within their work structure, whatever it may be. And when they take the role of the other person that they're having some conflict with or difficulties with, they get to increase their empathy, because then they're going to play that role, and you're going to talk to them while they play that other role, and they're going to see why that role does what it does, and it increases their cognitive empathy. The other advantages is when they're playing themselves, you can talk to them while they're doing that, of course, and they get to see what they're doing and maybe why they're doing that. Pretty interesting stuff. I like that stuff a lot. And then interpretation, where you're providing some of the connections. You're not just confronting things and suggesting. You're building an understanding. You don't want to assume anything, and you want to be sure the client can hear the connections, that they're stable enough and not too fragile. And it helps them to see patterns in their behavior. Okay? So, female has reports that she has had a large number of relationships in which she meets someone, is immediately sexual with them, and the relationship doesn't last long. And she doesn't know why this keeps happening over and over again. Why does she keep picking these males? Well, you may discover that she's finding these men in bars. You may discover that she's picking the wrong men, or the men are picking her. She may be exhibiting behaviors that suggest she's passive. She may simply be choosing people who are wanting to be sexual, and she's misreading the sexual behavior as interest in her, which it is not. It's interest in sex. So you may wish to interpret, saying, I notice there's a pattern for you here, that you start relationships, they are sexual immediately, and then they don't last long. And I wonder if you're aware of the idea that if you have sex very early, you may be creating a sexual relationship instead of a get-to-know-you relationship. That's an interpretation. Now, there are therapy styles, psychoanalysis and psychodynamic psychotherapy, which are good for anxious clients who are verbal and well-to-do, at least as far as psychoanalysis goes. They'd be good for personality disorders. Psychoanalysis is very long-term. Existential counseling, not many techniques, if any. The alliance and the connection you have is extremely important. This is good for anxious clients who are worried about the meaning of life, their role in life, up against really bad things going on. So this focus here is on self-awareness and expansion of one's consciousness and developing freedom with the concomitant responsibilities of that. Searching for meaning. Yeah. Person-centered counseling, this is where People need to feel accepted and have greater independence and make up their own minds and feel more integrated. And your authenticity is critical. Your accurate empathy of their condition is critical. Your congruence is critical. Gestalt counseling is, in its original form, is much more confrontive than it is now, but it is, wow, is it confrontive of the original forms. But clients who need self-awareness and reintegration, okay, who can tolerate some of that confrontation, of course. People who deny their own power, it's a very immediate, process-oriented kind of therapy. You know. Behavior therapy is good for people who have bad habits and maladaptive behaviors that they want to stop and in their place put in something that's much more adaptive. They'll do assessment and self-monitoring, and they'll do a lot of homework, and these people have to have motivation to do this. There's no insights. It treats symptoms, not causes. Doesn't talk about feelings much and the origins of the problems. Cognitive behavior therapy takes behavior therapy and adds the cognition part. So it requires that a person be able to do what's called metacognition, be able to think about their own thinking, who are prone to black and white thinking, who exaggerate, who confuse behavior with personal worth. People who are anxious, depressed. It relates cognition to emotion, and is a very teaching, somewhat confrontational kind of therapy. It assumes that if you change thinking, you'll change emotion, and it works. It's been used in a bazillion different places and for different problems. And it doesn't really spend much time on the remote past, the history taking, and the exploration of the past of the client. Now, for specific disorders, I'm going to list a few things that have been known to work quite well. So I'll take another tact here. For depression, cognitive behavior therapy. For anxiety disorders, behavior therapy, cognitive behavior therapy. For substance use and abuse disorders, person-centered therapy, cognitive behavior therapy, and what we call drug counseling, which is an amalgamation of things. Eating disorders, cognitive behavior therapy, behavior therapy. Something like schizophrenia, we want supportive therapy. This is where the goal is to build a trusting relationship and help them solve immediate problems, like taking their medication, like finding meaningful activity, if not work. Educating the family, educating the patient. That's what that is. Bipolar disorder, well, it depends on the individual person and whether or not they are taking their medication. If they are, which would be great. Bipolar folks often don't for particular reasons, but if they're taking their medication and are stable, then it depends on the individual as to what kind of therapy you might use. Cognitive behavioral therapy is used often to address the medication issue in particular. Sexual dysfunction, cognitive behavior therapy for paraphilias in particular. Personality disorder, depends, but it could be anything from psychoanalysis to psychodynamic psychotherapy to gestalt therapy to reality therapy, which is a William Glasser construction that keeps changing its name, but reality therapy is a good one. That's how I originally learned it. I learned it from the man himself. He's a fascinating person with a deeply wry sense of humor. If someone comes in with no diagnosis, then person-centered therapy, existential therapy, psychoanalysis, psychodynamic therapy, it would depend. No diagnosis means they don't have enough symptomatology to either in amount, kind, or intensity to give them a diagnosis. They're all subclinical. Okay, so just about anything. I like existential therapy for that kind of client on average, but it would depend on who's in front of you. Yes? Okay. So that's the what treatment do we use and what's it for? Take care.